My name is Muller, and I am the Division Chief of Pain Management and also a staff neuroradiologist at Fairfax Radiology, and I'd like to discuss the image-guided injections that we perform for treatment of shoulder and hip disorders. Hip and shoulder injections are also something that we frequently do. The reason being both of those joints are typically affected by arthritis and or other internal derangement, tendon injuries, labral injuries. But they're difficult to know for sure for the orthopedist whether they're actually in the joint. Orthopedists do a lot of injections in the office, and they're excellent at them, and they do them by what's called landmarks. They can feel around and they know the bony landmarks, and then they're able to do the injection. But it's difficult to know if you're actually in the central aspect of the joint itself by using landmarks alone. So that's where we come in with imaging. And we use the CAT scanner to confirm that the needle is in the joint space. Again, we use a little bit of contrast with the medicine, and you fill the joint. With the joint injections, we typically only do those once. Epidurals, nerve roots, you'll commonly hear we do them as a series. We'll bring someone, do it in once, we'll do it about 3 or 4 weeks later, and then maybe a third after that. And that's because those areas are very vascular and they tend to draw the medicine away and metabolize it. But in the joints, shoulders and hips, it's a bag, and that medicine will hang out in there and sit in there. It's non-vascular, and that'll be in there for a very, very long time. So we do those frequently. In addition, we also do, I just did one yesterday, we will do arthrograms of those joints under CAT scan for patients that can't get MRI, whether they have a pacemaker or whether they have profound claustrophobia or some other mitigating reason why they can't get an MR. We will do the same procedure, needle into the joint, distend it with contrast, and then do high-resolution scanning, allowing our musculoskeletal partners to accurately diagnose what's going on inside for our orthopedic partners. The injections are quite effective, and as I tell people all the time, the most common question I get is, well, what are the percentages? What are my chances of getting better? What will happen? And I always say the same thing to people. I said, well, I could give you numbers that may or may not matter to you, because all that matters is how you respond. And the reality is almost everybody gets a little bit better for a short period of time. The majority of people get at least moderately better for a moderate period of time, and then there's a decent percentage of people that get a lot better for a long period of time. The problem is we can't predict it. There's really no way of knowing. It's a combination of the individual. It's a combination of and not so much who they are. People often talk about well, I have a pain threshold, high pain threshold, or a low pain. I don't see it that way. I think that we're all built differently. Some people's pain is dialed up and some people's pain is dialed down. So it's really their genetic makeup. It's what's actually going on in their spine, and then it's the pharmaceutical, time, and frankly, a lot of luck. And so we always, by using the CAT scanner, when we're done with the procedure, I know the medicine is exactly where I want it. I know it's been placed accurately and safely. That we can control. The patient's response we can't control. That being said, even this week I had a couple of patients that when I first met them I thought, I'm not so sure I can really make a dent here. This patient may be going to surgery, and the two I'm thinking about just responded dramatically well. So I'm still, after 16 years, surprised at how well people do a lot of times.